Hello, everyone. Lovely to see some familiar names there and people who are joining. Dr. Milan Khara was joining us, is having some difficulty joining us as a panelist. So Rachel is just stepping out to get him on. So we'll give it another couple of minutes. And it's lovely to see you introducing yourselves to each other. And we really appreciate you being and joining us today. This is the the second one we're doing, a third one now, I think. And we're just, Dr. Khara and I are going to keep it conversational. We have slides. Yeah, of course, they'll be available to people at the end. And really, we're just using this based on the questions that came to us from you, and really trying to answer those questions. So I'll mute for a few minutes, and then I'll be back in a couple of minutes to get started. Since we have everybody here, we're going to let Rachel continue to try to get Dr. Khara in. So I'm going to get started because I know we have a lot of information to cover today and share with you, and you're taking time during your lunch, so I don't want to hold you up. I think I have control. Hopefully she has given me control. Can people see the next slide, which is our land acknowledgement? Can somebody type into, oh, Rachel's back. Okay. Oops. Rachel has stopped sharing. Ah, Rachel, you're back. Can't hear you.
Sorry, I can share it and then
Yes.
We can get started. Sorry about that.
Hi. All right. Perfect. Why don't you get started, and then any luck with Dr. Khara?
Yeah, I think he's actually on. I think I can just make him viewable to everyone in just a second.
Okay, why don't you do that?
Let me just try that out.
There he is.
Yes, he should be a panelist now. So Milan, if you're able to unmute, then everyone will be able to see. Yes, perfect.
Hello. Sorry about that.
Hello. Oh, no worries. Okay, all good. Okay, so take it away, Rachel.
Okay, thank you, everyone. We were just having some WebEx issues, but welcome Dr. Khara and Dr. Selby, who will be presenting on this month's Teach Educational Rounds, and it will be a vaping Q&A. And as Peter mentioned, we'll start off with our CAMH land acknowledgement. CAMH is situated on lands that have been occupied by First Nations for millennia, lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of CAMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they were known at the time. Today, Toronto is covered by the Toronto Purchase, Treaty Number 13 of 1805 with the Mississaugas of the Credit. And Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. CAMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis, and share the land and protect it for future generations. So now I invite everyone to share where you're joining us from today. And you can also add on to that and share something that you're currently doing to learn or improve your commitment to reconciliation. And if you're not sure where you're joining us from today, I'll put a link in the chat right now that you can use to find out. And in the meantime, I'll just get going with my own personal land acknowledgement. My name is Rachel. I am a second-generation Canadian located on the lands of the Mississaugas of the Credit, which is covered by Toronto Purchase Treaty Number 13. And I continue to listen and learn about the stories and cultures of various Indigenous communities and ensure that their voices are heard. So just for the sake of time, I'll keep on going, but everyone is welcome to continue sharing. And I'd just like to briefly highlight an upcoming TEACH training, the Foundational Health Educator Workshop. And this is a key step for earning the Certified Tobacco Educator or Certified Respiratory Educator credential, which are both offered through the Canadian Network for Respiratory Care. And this workshop is great for healthcare professionals to gain essential competencies needed for tobacco prevention and cessation. And it's a great opportunity to enhance your skills and advance your career in tobacco education and care. And this year will be in September 18th and 19th, and it's taking place in person at the CAMH site. And there's a QR code on this slide, but I'll also put a link in the chat that you can use as well to learn more or register. And if you have any questions, you can reach out to us at teach@camh.ca. And moving on with just a reminder that if you wanted to receive a letter of completion for this Teach Educational Rounds, to make sure that you first registered for this webinar and completed the full pre-learning assessment. Also signing into this webinar using your first name and last name so we can identify you, and to complete the evaluation and post-learning assessment, and both of those will be sent out at the end of this webinar. And so a bit about our presenters today. Dr. Milan Khara joined the Vancouver Coastal Health in 2003, having previously worked as an addiction medicine consultant at CAMH. And he is certified by the American Society of Addiction Medicine, and his current work primarily focuses on treating tobacco use disorder, but also extends into other areas of tobacco control. And Milan's research interests have mainly focused on hard-to-treat populations and have been published in medical journals. Dr. Khara has also been involved in many areas of tobacco control advocacy, including providing testimony in challenges to smoke-free legislation. And he has also appeared as an expert witness before the Standing Committee on Health to contribute to the development of a federal regulatory framework for electronic e-cigarettes. And I'll give you a moment to read through his disclosures. And we also have Dr. Peter Selby here with us. And Dr. Selby is a senior scientist and senior medical consultant at CAMH. He is the vice chair research and Giblon professor in family medicine at U of T. His research focuses on innovative methods to understand and treat addictive behaviors and their comorbidities. And he uses technology to combine clinical medicine and public health methods to scale up and test health interventions. He has received grant funding totaling over $100 million from CIHR, NIH, and Ministry of Health, and has published over 200 peer-reviewed publications. His most recent program of research utilizes a learning health systems approach to investigate how technology, equitable, collaborative care can enhance the delivery of evidence-based interventions to the patient while providing a more satisfying experience of care for patients and providers across systems. Welcome, both of you. Thank you for joining us again for another Vaping Q&A. And I'll give you a moment to read through Dr. Selby's disclosures. And this is just a note that all Teach Education Arounds presenters are offered an honorarium. That being said, presentation content is not affected by acceptance of this honorarium. And the content of Teach Educational Rounds are centered on evidence-based guidelines from the following sources. And these materials, as well as their verbal presentation and any discussion, represent only general principles, and they do not remove the need for clinical assessments or treatment plans by healthcare professionals. So with that, I'll pass it along to Peter and Milan to get started on their presentation today. Thank you both.
Thanks, Rachel. Welcome, Milan. I'm just going to, as we said, keep it conversational. So let's control file. I can do it. Can I? All right. I have co-host. I'm the presenter. Okay, so now I can move it forward.
Is it allowing you to move forward?
No, it's not allowing me to move forward.
Okay, I'll move it.
Oh, wait, hold on. Let me try this. Okay, can you see them? Did it move forward? Yeah, it's gone to learning objectives. Perfect. Okay. So we're going to cover three themes. Obviously, these are based on the questions that came to us. State of evidence surrounding vaping and its harms, and when and who you should suggest they use it. What about managing dual use with cigarettes? And of course, how do you help the population that want to quit vaping? So, and we have resources for that. So it's clearly on our Intrepid website. There's a resource for all of these questions can be answered. So, Milan, we've been asked to talk about these three things. I know we're going to keep back. We've got only about 45 minutes, so we're going to invite people to put questions in the chat, and we'll try to get to all of them as well. But here are the questions that came ahead and what we've designed the webinar about. So, would you as a physician recommend vaping as a cessation aid to adults if all other cessations have not worked for this purpose? And then, are there benefits to using products to quit smoking? In lieu of patients interested in using any other forms of reducing smoking, is vaping a consideration harm reduction? And does the evidence support vaping should be considered a form of harm reduction compared to smoking cigarettes? So I'll open it up to you, Milan, your thoughts, opening thoughts before we get into the slides.
Thanks, Peter. Hi, everyone. I think this is actually a very nice slide. It kind of encapsulates the crux of the debate, right? And the questions are: can we use vaping as a cessation tool? I think most people now know that yes, that's an option for us. That vaping can be considered as one of the so-called pharmacotherapies, even though it's not approved in this country. It's increasingly seen as legitimate, and you're going to show some of the evidence, I think, as we go.
Yeah.
And then, of course, the question of what about not as a cessation tool, but as a switch to a apparently less harmful alternative to cigarette smoking. So harm reduction, is this the methadone for those with intravenous opioid use? Again, I think most people now know that the answer to that would be yes, that we would yes. encourage that if that was the only option, of course, with caveats, which we'll get to. And then last of all, what about, again, flipping it on its head, what about those who are addicted or compulsively vaping? What can we do to help them? So yeah, this slide captures it all, and maybe we start working through it.
Yeah, let's go. So vaping as a cessation tool, we go to the Cochrane database of systematic reviews. This is like the gold standard of taking and collecting high quality evidence and putting them together, analyzing the results from all these different studies and say, if you look at the body of research beyond one study, are you seeing evidence that says, yes, you should do this? So this group, which is the tobacco addiction group, at the Cochrane review has really come out and looked at these comparators. So nicotine e-cigarette versus NRT, nicotine e-cigarette versus non-nicotine e-cigarette, and nicotine e-cigarette for behavioral support. So if you look across, you'll see it tells you the number of studies and how big the samples were. So you're basically seeing close to 10,000 people in this, if you take all these studies together, roughly. And it tells you the risk ratio. And so risk ratios, if you don't like to understand it mathematically, you can convert, and to convert it to patient language, you can say a nicotine e-cigarette shows significantly higher quit rates than NRT. So if you're making a choice between NRT versus e-cigarettes, basically what it says, you'll get 4 additional quitters per 100 people. So per 100 people treated with NRT. So in a way, it's coming out on top for that. If you have e-cigarettes with nicotine, it does also have benefit. So which is basically telling you it's not just a placebo effect. There's benefit to having nicotine in the e-cigarette. And then nicotine compared to providing counseling alone, you can see that you again get 4 additional credits per 100. So that's what we are really talking. And if you look at the risk ratio, it tells you if you did these studies again, you're going to find the results in 95% of the times between those 1.29 to 1.93. So that's where you'll find the results 95% of the time, somewhere in between. On average, it's at 1.59. But basically, if you did this study many times over, you'll find it between those results. So that's what it's telling us. So in a sense, it's telling you, yes, this has efficacy for helping people quit smoking when you compare it to placebo e-cigarettes, when you compare it to NRT, or you compare it to behavioral support alone. And Milan, let me always invite you to interrupt as I'm going along, but just here's what we're going to also tell you. They've also done interesting studies where this is called a network meta-analysis, and you may have seen this during the pandemic for COVID medications, but a network meta-analysis is that if drug A has been tested against drug B, and drug B has been tested against drug C, then you can analyze A compared to C because B is common to both. So these are what network meta-analysis are. And again, they've looked at the interventions of nicotine-containing e-cigarettes, varenicline, cytosine, bupropion, and patch, single dose. And basically, you'll see that you're getting an effect for nicotine-containing e-cigarettes, Champix, or varenicline, sorry, I shouldn't say Champix, is no longer available as Champix. It's varenicline is generic in Canada, and cytosine. You can see the numbers and fairly good confidence intervals that the odds of quitting are quite up there. And you can see that there's evidence for each of these things, but the ones in blue are becoming the more dominant. So e-cigarettes, even though they're not approved, as Dr. Khara said, the evidence is suggesting that you're going to get good results with high confidence between nicotine, if you chose a nicotine-containing e-cigarette, varenicline, or cytosine. You still get quits with bupropion and patch, but not as much. And then the research suggests that obviously combination patch plus a fast-acting had similar rates of quitting using e-cigarettes, varenicline, or cytosine, but because you've got broader confidence intervals, they're not as confident in the findings. So that's what the Cochrane review has said. And Milan, is there anything you'd like to add? And I think Lynn has asked whether fast-acting NRT is the spray. Yeah, nicotine spray, nicotine inhaler, lozenge, gum.
Yeah, very nicely summarized, Peter. Clearly, before e-cigarettes, we were kind of coming to this conclusion that based on efficacy alone, varenicline plus combination varenicline and combination NRT were the most efficacious approaches, and they were similarly efficacious. And this body of evidence now is starting to suggest that nicotine e-cigarettes are in line with that. Now, again, whether that means that you offer it with as much enthusiasm as combination NRT or varenicline. Again, there are caveats, but purely in terms of efficacy, the evidence is seeming to suggest that it's similar to those two options that we would usually preferentially choose.
Yeah, absolutely. And I think David has answered Marilyn's question quite well. There's too much variability to do any kind of direct conversion into NRT equivalents, or cigarette equivalents. It's really you have to really help people understand only vape as much as till you need it and do it mindfully. All right, moving right along. As a cessation tool, obviously, if people are going to use it, then obviously you're doing a full switch. It's not like I'm going to vape when I can and smoke when I can. That dual use is really problematic because now you're going to generally get higher nicotine exposure, and you get exposure to different chemicals that you never had. So again, obviously, if you switch completely, and I think this speaks to it, on a dose-to-dose exposure, you get less exposure. It's very hard to compensate on a vaping device to get as much exposure to acetaldehyde and all the carcinogens that you would get from cigarettes. It's just you can't. You'll get poisoned by the nicotine in there. But having said that, the long-term health effects of e-cigarettes are known. And what that means, I think, for me, is that if I have a young person who's in their 20s, hasn't tried to quit, and is vaping, I'm going to say, you know what, long-term, we really don't know. And I would strongly advise you to quit vaping. It's not like, oh, you happen to vape, nothing to worry about, and you go along. And I think this has been like taking another addiction into, we've sort of minimized the harms from cannabis smoking. Nothing bad from cannabis smoking. But now, just last week, more and more data coming about its long-term effects on cardiovascular health. And so, that's long-term vape, smoking of cannabis. It's not the first time you have a joint that you're going to get. So if a young person is taking it up, I'm really concerned about, we really don't know the long-term health effects. So, we really want to make sure that people understand that this is more for people who are unable or unwilling to quit, and they're looking for an alternative. Milan, your thoughts before we go on to the next few points around that?
I mean, you make a very good point. We always have this caveat about we don't really know what the long-term health consequences are going to be, but that statement is of no relevance for a fellow who is 60 or older with end-stage COPD, who can't have success with conventional approaches. That concept is irrelevant, and we should be offering those folks e-cigarettes as one of the options, in my view. And I'm sure that's what you're doing clinically.
Yeah. Oh, absolutely. And I mean, yes, we know that if somebody stays on e-cigarettes and they're coming off e-cigarettes after some point in time, if they're going to relapse to cigarettes, we say if you're better off relapsing back to your e-cigarette. Maybe it's too soon to come off, and you periodically try helping them come off that. Obviously, people need to follow the instructions of the device, and more we are seeing people, especially older people who are going to use it, actually prefer the disposable because there's not a lot of fiddling and refilling and all that kind of stuff. So, really we say, look, use what works for you. Make sure you're not overdosing. Use whatever is legal because, it's the 2% that is the legal limit in Canada. But we know people are getting the 5%, etc. So use what's legal in Canada. Avoid some certain flavors. And we've been over that before, so I won't repeat it again. And most of them aren't around. But, use the one that keeps you comfortable as little as you need to keep you comfortable, no more, no less, and follow the instructions of the charger, etc. These are electronic devices. And one more thing which is missing from here is that these have lithium ion. These should be disposed properly. And in fact, in our clinic, we actually have ordered proper disposal containers for vaping devices. Because they should not be thrown in general garbage, and they do have an environmental impact from that. Of course, cigarettes shouldn't be thrown into the streets and and contaminate our wastewater as well. There needs to be better disposal of these devices. Okay, and some vape stores actually will, as a way of business, will ask people to return the device because then it's also for helping their sales. But in general, we need to have a better disposal system. So if anybody is a policymaker here, works with cities, we really need to have a better approach to devices and disposal. If vaping cessation is tool, we have our updated lower risk nicotine use guidelines, the recommendation, the evidence briefs, quick tips, and executive summary. If you scan the QR code, you can get it, or you can find it on our website. I think there's a whole bunch to hear in terms of if they are going to take it. This is a paper from Fu about, if they going to use vaping, it's amazing how many people don't want to take up vaping as a way to quit. They're still saying, no, I prefer my cigarettes, and they've tried everything. So Milan, maybe you can talk a little bit about this as well, of how you know, around this slide, how you approach it.
Yeah, so my conversations around the use of vaping as a cessation tool are probably still quite conventional in that I certainly want to explore the use of all the approved first line products first. So just,
Yeah.
I've said that once already, but to be clear, I do want to make sure that people have used combination NRT or have used varenicline or have used these products in combination, this kind of titration approach that we use in smoking cessation, or that we should use in smoking cessation that often doesn't get done. So I'd really like to know that someone has used the conventional approaches adequately before thinking about vaping as an option.
Yeah.
And in all honesty, when you take that approach, you get to vaping less often than you would imagine. There's almost always more you can get out of the conventional approved products when used aggressively than you might imagine. Now, having said that, when we do get to the end of that line, I think one of the things we don't talk about enough is, or certainly for me, one of the areas of discomfort is that when we start to talk about vaping, I don't feel entirely confident giving very
Yeah.
specific advice around which product,
Exactly.
which dose, which flavor, because it's an unregulated, largely unapproved
Yeah.
device.
Yeah.
And then we're sending our patient off to a vape store where they may be met by, you know, an 18-year-old on minimum wage who has now become the healthcare provider. So that's an area of discomfort.
Yeah.
But I don't think that means that we don't bring vaping
Yeah.
into our conversations at the right time.
Yeah, and it's, you know, it's the same issue with medical cannabis, right? Like people are going not necessarily getting an authorization; they go to the recreational market and getting their cannabis. So, and you know, it's the bud tender educating them about it. So we provide general information, and I think, but from a clinical perspective, you know, notwithstanding the device, we give broad level sort of advice. But it's really these things that we talk about is like, one key message is, you know, this is not addressing the addiction. It's maybe reducing harm, but it's not addressing the addiction piece. You're still going to have to invest your money, still going to have to buy something, but here's what you're going to get from it. But again, these are the other things. You know, sometimes vaping, people say, I don't like the look of being a vapor because other, you know, that conflicts with my identity as a smoker, etc. Friends may laugh at me. So all of those kinds of things. And again, you know, some people have the side effects. They get dry mouth, they get dry, you know, if they don't. So we educate them to like drink lots of water because the propylene glycol and vegetable does dry you out. So, you know, it's not something without, you know, topical side effects. And make sure when you're choosing a device that it's at least, you know, it's not just something you bought off the back of a truck or something, that you've gone to a store that, you know, you can look at the packaging, look at where it's manufactured, do some homework. And then clearly, you know, what are you giving up when you switch to vaping? Because people sometimes are saying, I want that throat hit that I get from a cigarette. Sometimes you don't get that with vaping. And some people, you know, so manage expectations is what I do with people and say, what do you expect? And how do you give it a try? And how do you figure it out? You don't know. With a cigarette, you know it's burnt down. And even though you only needed 3 puffs, you smoked the whole cigarette to saturate all your receptors. With a vaping device, you don't have any visual cues. So you need to just make sure you pay mindful. I call it mindful vaping. Go outside, take a puff, see how many puffs you need to feel comfortable. Don't let it become an automatic or don't become a grazer. So those are the kinds of things we talk about to help people sort of walk through you know, to prevent themselves. And then I said, whenever you're ready to come off it, we have options to help you come off it, maybe breaking it down into stages. So, okay, I think we've covered that, and there's some questions. We've talked about disposal, chargeable, etc. So we're going to move into, yeah, the handling and the smell of e-cigarettes. It isn't the same, that feel and stuff, and that's all conditioned behaviors. And so sometimes it's like helping people make decisions around trade-offs. What is your ultimate purpose? Yes, this is a trade-off, but is that trade-off what really matters to you? You know, so often we are spending time with people saying, you know, what is the purpose of coming here? What matters to you? Well, I want to have some comfort. I want to have this, but I also want to have time with my grandkids or better health and all those kinds of things. So we say, okay, that's the trade-off. So how much are you willing to give up that sensory feel and watching plumes of smoke go up in the sky so that you can actually do that? And so that's that values clarification that we have to do in a very quickly, so that people can then say, yeah, you know what, I'm willing to compromise and give that up because I want this other thing more. And if they're not, then they're not. Anyway, coming to the dual use, these are the questions we have to us. So your strategies to control vaping and smoking, who do both, um, and and what do you think? You know, when they feel vaping is safer, how do you ask them to quit both? And there's conflicting information regarding dual use and vaping devices. That people who use dual use smoke less, thereby differing harmful effects. So they want us to discuss this. So I'll ask you all the tough questions.
Well, before we get to that tough question, I'm just reminded of a very common question that I get,
Yeah.
which I don't think needs discussion, but it is interesting how frequently the resistance that I get to my recommendations to consider vaping is that patients still believe that vaping is as harmful as smoking or more harmful than smoking.
Yeah.
Do you continue to hear that
Oh,
misconception?
absolutely. And they said, you know, because in the newspapers, what came out was the harms from vaping and the public health messages and don't. So what happens is that they say, well, if that message is out there, then yeah, it certainly is. So often I have to, and I don't know how you address it, but I really start up by asking an open-ended question. So what is your understanding of vaping and the chemicals in vape compared to smoking? And then I get a sense where they're at and what have you heard? So we start from that, because if I come on too strong and talk about vaping and suddenly they say, but they've got in their head all this stuff and all these images and what they've heard on the internet, right?
Right.
I mean, this has become the
And
way I practice medicine. It's the same thing with varenicline. You know.
right. Yeah, no, I couldn't agree more with the approach. But interesting how often I hear that the information has allegedly come from their family doctor, in inverted commas. Now, whether that's
Yeah.
truly what the exchange was like, or whether this is the interpretation of the exchange is always hard to know. But that misconception is alive and well. So your question about the dual use, again, you know, you made the comments earlier about how we're now seeing individuals who have got exposure to two lots of toxicants,
Yeah.
and maybe an increased number of toxicants, and potentially an increased use of nicotine. And my advice around dual use is always, well, look, let's get you to the less harmful of the two products. So we're trying to move people to vape alone if they've got dual use. But it is an intriguing question, isn't it? That if somebody has gone from smoking a pack a day
Yeah.
and they're now vaping, but they've got a small amount of cigarette use, it's hard to imagine that dual use is more harmful than just smoking. It almost certainly isn't, right? But I guess it's hard to capture that in research. So when someone is transitioning towards vaping, even if there is a period of dual use, I think we need to be supportive and collaborative in that situation, and trying to move them along the readiness continuum to vape only.
That's right. And I think there's a great question that Helen said, is obviously the long-term effects are not fully understood. I think here's what it is. The long-term effects of smoking are very well understood. And it is based on where we're at. If the choice is between the two, just by, you know, our evaluation of what the dose exposures are going to be, there is less likelihood to be these other things. Where the jury is out, and I think we need to pay close attention to, is obviously the impacts on the respiratory and the lung system. And that is one of the reasons why we need more refined and better products that are regulated with proper DIN number, etc., so that you can track what happens. Because right now what's happening is cigarettes are getting an unrestricted approach to continue. And clearly with this new settlement and the way the money will flow, it's based on cigarettes being sold. So So yes, it is one of those things, and we do need to be cautious, and people need to take, a cautious, aspect. And I say, when I talk to patients, I say, yeah, we're not suggesting you switch to vaping for life, but we're talking about as an interim. Because when you come to the vaping side of things, once people have switched to vaping, I find over time they come to a point and just say, I want to stop. So we are finding that transition a lot, and they're finding quitting vaping a lot easier. So I don't know if that's been your experience, but so when we look at this dual use, we have to look at that continuum and the pattern. I think what is happening is sometimes we have people who've done well with vaping, but because of the public messaging come out, they're going back to smoking. And I'm trying to say, wait a second, you were getting close, you know, uh, and that's it. And then the other one I find, I don't know about this, is that they find sometimes, especially getting contraband cigarettes, a lot cheaper than even vaping.
Right.
So the financial patients who are financially off find it a lot easier to get contraband because the contraband comes to them. Somebody's selling it to them. Whereas the vaping devices, they have to go into a store, they have to, get it, ask, and it often can't navigate that. It's easier for them to get these contraband cigarettes. So that's a challenge for us. And
Yeah,
I don't know how
and
that's for you in
yeah,
Vancouver, but
and Peter, just to amplify the comment that you made, in case our audience is worried about that statement that the long-term health consequences are unknown. That statement doesn't stand alone, because what should be in the brackets of that statement is that though the long-term consequences are unknown, there is a growing evidence base that it is highly likely that vaping is going to be less harmful than the very known risks of tobacco use, right? So,
yeah,
it's not that it's just an unknown; it's that it's an unknown in absolute terms, but the strong likelihood is that it's going to be substantially less harmful even in long-term use, right?
yeah,
Again, despite the concerns about respiratory effects, etc., we acknowledge all these things, but these things have been around for 2 decades now, and we can't yet say that long-term use of electronic cigarettes corresponds to a times 2 or times 3 increase in cardiovascular disease or cancer or COPD. We can't say that yet, even though there are things for us to be concerned about. So the long-term health consequences are unknown is not a statement that stands alone. It should be clarified by saying, but the evidence seems to
yeah.
suggest that the risks are much lower.
That's a great way of putting it. Yeah. Thank you. So here's I mean, there are some interventions for dual use, and you know, uh, essentially, you can see that they targeted booklets for dual users, including vaping and smoking booklets. So they did a couple. This is from Tom Brandon, who's worked with us in the past, and Tom Eisenberg as well. Um, and Dr. Bullen as well. So I think this is an interesting option. And you can see that when they do both, it does make a difference. But once the intervention ends, like with all smoking cessation interventions, um, they tend not to persist. But there is some evidence that you could do both if they want to quit both. And again, nicotine-containing e-cigarettes support more effectively than NRT or nicotine-free e-cigarettes. So if people are switching, they should be, switched completely. And that under Canada, we have this regulation of e-liquids have 20 milligrams per mil, banning sales to minor, and also now moving towards a flavor ban, which is kind of controversial because although it might help prevent uptake by youth, adult smokers like that flavor, and flavors might have some evidence. So I think we have to, yeah. Now, and I think understanding vaping when we'll come to it, short term as a cessation aid is one thing. It's like anything long term. Whether it's NRT long term, like for example, the lung health study had people who took gum forever. That long term effect is a harm reduction option where they're not going to give up their addiction to nicotine. They're going to stay depend on nicotine, but a least harmful format. And now we have this other option, which is vaping as a way. And of course, there's another one which is on the market now, which is pouches, and we're not talking about that today. But again, that's another one there. And you got to look at these various formats. yes, people will stay dependent on it from the nicotine, but the harms are dependent on how it's taken, inhaled by smoke, inhaled by vape, or absorbed through the buccal cavity. So, and in terms of social pressures and things that people are doing, I think the social pressures are quite heavy in the younger age group. You're seeing this idea that it's varying, because you've got this, the prevalence of smoking in school age kids is down to like 1%, both in the US and Canada. And it's really low, but vaping has gone up. And now with the anti-vaping messages, you're beginning to see an uptick of smoking, especially in popular movies, etc. And so it's an interesting dynamic that depending on where the young person finds themselves, the social determinants of vaping versus smoking will be evident. And in our clinic, where we are seeing youth who vape, mostly they have comorbidities, and their social influence varies depending on their type of product, on who they hang out with, what they see on social media, etc. So dual use is very variable from that perspective. I don't know what you're seeing in BC, Milan, but would you care to comment?
Yeah, so a couple of things before I comment. I mean, you just touched on flavor bans, and you described the kind of the difficulty of on one hand trying to make these products less attractive to youth, but also inadvertently making them less attractive to adult addicted smokers who may want to quit.
Yeah.
Is your position that you wouldn't support a flavor ban, or you would?
Well, I'm mixed about it, because I think part of it is we really need to get adults to use it and prevent kids from using it. That's the issue.
Right.
Unfortunately, whatever we've done has flipped it, where kids have easier access and adults don't. So we need to have, and this is one of my recommendations I made to when they were the Senate Curing Committee, is that we need a third pathway, and developing it like the or like in the UK, where it could be used on that pathway as a harm reduction product. Prevent the advertising and promoting of a lifestyle product like they've done in the US and in Canada, and now allowed in the US, whereby you had low prevalence and uptake by youth, and actually high uptake by smokers who are not. And so, for example, offering it through the NHS, those kinds of things, in which case I want people to use the flavor. Imagine if we had no flavor to nicotine gum. It used to be a flavorless product when it first came out. Nobody used it.
That's right.
So,
and people still talk about how awful it was.
exactly. And you cause an aversion for it. So that's the issue. What are we trying to do? Why do we want to make people who are addressing their addiction suffer? I have no idea. Why do we make it so uncomfortable for people to recover from their addiction, but easier for them to stay addicted? So anyway, but we have only about 15 minutes left, and there's some good question, and I think we should just make sure we get to the next part of this, which is answer some of the questions in the chat. Health effects. This is about fetus, secondhand and third-hand smoke, recent research about the harms of vaping on the lungs, popcorn lung, value issues coming up. How do you address these concerns when asked? And can vaping cause cancer? So very quickly, let's just run through. There's lots of data, so I'm going to run through them, Milan, and please interrupt me as I go through. Just here's a great slide that shows you all the harms around all the bodies. So please look at this. I think it tells you what the harms for non-smokers are, and for smokers. And so it's about absolute risks versus relative risks. And these are the things that you can look at, what may be attributed to nicotine versus attributed to the constituents in there, and you can see it's color coded. And then if you take a look at our Project Vector, we actually have those recommendations on that, and that's on our website. On fetal development, clearly, in pregnancy, smoking is awful, because not only does it deliver nicotine, it develops carbon monoxide, it develops other toxicants as well. And the question now becomes, what about e-cigarettes and aerosol? And of course, you're going to have harm. You expose any developing embryo to any effect of any substance, you are going to have negative effects. So, that's not on any doubt, absolutely. But the evidence that we do have in humans suggests that pregnancy has little effect on birth rate, but we don't have good quality evidence. And clearly with everything else, it's a last resort for those unable or unwilling to use nicotine replacement or medications for smoking cessation, including support for themselves, their partner, etc. We've done the pregnancy stuff before, and clearly that's a population close to my heart. Really, obviously, you want to have a woman and her family optimized for the pregnancy, and not just with their smoking, but everything from social determinants to other health determinants in place, so they themselves can have the best possible experience of pregnancy, but more importantly, what happens to the woman after. And that this is not just about the fetus, that we're taking a woman-centered approach to their care. Third-hand vaping exposure, residual e-cigarette chemicals and services may harm health, especially children, but it's really interesting. This is in mice but again, if you take a look at it, if people are vaping outdoors, this is not relevant. So really main thing is when we tell people to vape outdoors, don't vape indoors. Because it can expose, and it may expose your pet or young people, your kids to it, but way less than you would get from cigarettes. Ideally, there's a whole bunch of effects on the lung that have been summarized in this paper in 2025, and when you take a look at this, these are the things that have been thought to occur. But what is not clear, even this EVALI, which has suddenly, miraculously disappeared, has been attributed not so much to vaping nicotine, but vaping contaminated ones that were modified to include THC and vitamin E acetate. And as of now, if you think about with the legalization of cannabis in the country since 2018, where people can vape cannabis that is butane extracted or otherwise extracted, and THC strengths of 90 to 98%, why aren't we seeing EVALI in that population? So I think there's something about having substances regulated. We're not seeing it. Yes, in the lab, you're going to see these issues, but in the real world issues, it's not that you discount it. Clearly, inhaling anything is bad for you, but guess what? If you have a client or a patient who's burning candles in their home or incense sticks, and they're doing this regularly all over the place, then yes, you're going to see these same issues because you're getting exposed to, to particulate and aerosolized matter. Cancer risk, again, nicotine is no cancer risk is found, and this is done obviously as part of Project Vector, and there may be some biomarkers, but really the limit is negative. As you know, nicotine in of itself does not cause cancer, but in patients with cancer, it can act as a pro-cancer carcinogen. So we are a bit cautious in patients with cancer, even using NRT for long term. We tend to limit it for as long as is needed to stay stopped, but not as a long-term option. Again, the jury's out about that. In the last 10 minutes, the interventions for vaping cessation. Before I jump to that, Milan, any comments about the harms?
No, Peter, I think the next part is a really important place to spend 10 minutes, so go ahead.
Okay, so varenicline for adolescents, what are your pharmacotherapy options? Besides NRT, what else can we do who are not ready or preparation or stages, and how do you use NRT for vaping? And use NRT in vaping, including dosing, behavioral strategies for vaping cessation. I think we should have had a whole session just on this one. Maybe that's the next time, but we'll give you a teaser in the update. So clearly, these are the interventions to quit vaping that the same group, the Cochrane Review, has said. But if you take a look at the certainty on the grade recommendations, the quality of all these mechanisms were low. But in the varenicline, it does double the quit rate. Combination had imprecision. Cytosine was promising, and very low of looking at a vaping reduction plan. We try to do it, but very small number of participants, only 17, so it's really limited. But text-based messaging does seem to have some support. And so 29 out of 100 versus 22 with support. But again, the certainty of the evidence is low, but this is for young people, that it might have some benefit. And so it's out there. Let's go to the next slide. I don't know why it's not showing up for me. Okay. NRT, minimal evidence, cytosine. We're going to cover that. 3 milligrams for 3 days for 12 weeks does seem to have benefit. And this was a US study. Bupropion not out there. And then you see this, another study of varenicline is showing continuous abstinence while they were on it, and up to 24 weeks compared to placebo. And again, does seem to show promise for that. And this is the latest study that's come out for youth nicotine vaping cessation. It's a randomized control trial published by Dr. Evans. And in this, which was a randomized clinical trial, they had 139 women, 122 men, so quite a good sample size, mean age of 21, in one hospital in Boston. They got varenicline, placebo, or enhanced usual care, which is text messaging. And then they looked at continuous vaping abstinence for the last 4 weeks of varenicline treatment versus placebo. And you can see the rate of vaping abstinence was 51% in the varenicline, placebo was 14%, and enhanced usual care was only 6%. So it really does show efficacy there. Odds ratio was 6.5. And the compared to placebo, and 16.9 compared to this enhanced usual care, which is 12 text-based messaging. So I think for young people, because it's not addictive, because it's a fairly well-known drug, it's generic, I'm moving more and more to saying varenicline should be our first line. You're not worried about trying to do conversions to NRT, all of that stuff. It's a pretty standard dosing protocol. We know what the side effects are. There's safety. So maybe I should ask you to comment. I know we have only 5 minutes, but would you like to comment on the study?
Yeah, I mean, it's a really important addition to our knowledge base. I would echo what you said. I've spent a number of years using primarily short-acting NRT for young people who vape, essentially in a void of evidence. And studies like this are going to really help us to move things along.
Yeah.
Of course, we've used pharmacotherapy in those who vape based on the conceptual belief that nicotine addiction is nicotine addiction is nicotine
Yeah.
addiction. But these kinds of studies are going to come along and are going to help. And I also will now use varenicline with a bit more enthusiasm than maybe short-acting NRT in this population, based on the findings of this study.
Yeah, and Dan and others asked, why haven't pharmaceutical companies gone into this? The biggest reason is because there's a recreational market. There's the risk of creating a therapeutic product is a risk of failure so high, and shareholder value will drop. So, you know, you have to do if you do a vaping device, you have to do animal studies first. Then you have to do on the device itself, then on the liquid itself, and then you've put all this money in. And if you get, you know, a middling result, you know, you're not going to make any shareholder value. So there's no financial incentive to do it, and too much risk. And you're seeing the same thing with cannabis products and THC, and there is too much risk. And so because you've got a recreational market happening, so we are stuck, I think, in this space. Unless something changes in the regulations, we're not going to see a regulated product. There's a pathway, but nobody's picking up. I mean, you could go to Health Canada. If you had money and you had the pockets and you had the willingness, Health Canada can take an application to do it. But I don't think you're going to see anybody do it in the short term. I think people are trying. Cytosine is called cytisinicline because they want to make it into a patented drug in the US. And this is the trial led by Dr. Nancy Rigotti, Benowitz. And really, this showed that it does in adults who are using nicotine-containing e-cigarettes, 160 people, 107 with cytosine and 57 with placebo. Notice it was 3 milligrams. So in Canada, you get the 1.5 milligram capsules. So it's typically, so this is 3 milligrams 3 times daily for 12 weeks. And you can see that you got 31% quit versus 15%, so half as many at with cytosine. So I think it's cytosine, if you can get your hands on it or your patients can afford it, really good option as well. And then youth vaping, I think we're going to have to push this off. But what I will say is, if you've asked in Ontario, if you're joining us from Ontario, we've set up a new program called Youth Vast, where youth or their family or their teacher or the healthcare provider can refer them to us. They will get an assessment with a care coach, and the care coach will then get them into, they can be anywhere in Ontario, it could be in person or virtual, and they can get care through a therapist as well as a physician to manage their vaping and any comorbidities. We can also take referrals for other substances as well, but that's really where we are at. Oops, I jumped over it I think I jumped over it. Yeah, that's the Youth Vast. You can make a referral. It's ages 12 to 21, and it's an interdisciplinary team that comes together around these young people who are vaping or using substances or gaming, or all three. And that's the purpose. Okay, and really, it's these are some of the clinical level issues that you can do. Making sure you always screen people and their family members if they're using. And then provide treatment. And I think what we'll do is, I'm going to skip ahead today because I don't think we can get to it. But if you go to the slides which will be shared, you can see what are the tools that you can use and what we are using in Youth Vast as well. There's a whole bunch of resources there. And I know we're at time, and I think we've answered all the questions. But Milan, you get the last word here. Anything we missed? Anything you'd like to comment on?
Yeah, not a lot to add, Peter. Thanks for running through that super quickly. I just reiterate that there's some great slides there, and if the things that we haven't covered well, then people should go back and take a look. And I know you've made your email address available. Mine is there as well if there's any questions. And I particularly like the clinical questions because I think all of us are kind of finding our feet and working in something of a void of evidence this last few years, and conversations about what others are doing, and I'm happy to share what I'm doing are mutually beneficial.
Yeah.
Thank you both. Yeah, we are at time, but thanks for taking the time to answer everyone's questions. And like Peter said, Dr. Khara's and Dr. Selby's emails are both on the slide. If you have any questions, we also do, I'll just say next month, we'll be having another vaping Q&A that's youth focused with Dr. Trish Tulloch, who is also from CAMH and Sick Kids as well. And that will be exactly a month from now on July 23rd. So if you're interested in attending that one as well, registration will be coming shortly. And at this point, if anyone has to go, I know we're at time, so please feel free to, and it won't impact your attendance. I'm just going to do some last minute reminders. So if you want to receive a letter of completion, just a reminder to complete the evaluation and post-learning assessment, and those will be sent to you shortly after the end of this webinar. And if you missed a portion of today's Teach educational rounds or would like to view it again or any of our others, we have an archive list on our website that is available too. And thank you for now. We'll see you next month. And again, a reminder that all the resources discussed will be shared with the slides. And thank you everyone for attending, and thank you, Milan and Peter.
Yeah, and thank you, Milan, and thank you, Rachel, for organizing and troubleshooting and getting us here. And thanks, everybody. Have a great rest of your day, and see you in July.
Bye,
Thanks,
everyone.
folks.
Bye. Thank you. Take care.